On behalf of my co-authors, we presented an analysis of the JVDF study, which was a study of Ramucirumab, a VEGFR2 antibody, in combination with Pembrolizumab, an anti-PD-1 antibody. Certainly, we're looking for ways to increase the efficacy of PD-1 inhibition. And one thing that has emerged from the preclinical as well as early clinical studies is that VEGF inhibition seems to play a role. Certainly, if you combine with a VEGF inhibitor, in the initial paper that's published in Lancet Oncology, we showed in the lung cancer cohort, especially, what looks to be increased response rates and improved progression-free survival in patients with lung cancer who received the combination Pembrolizumab, Ramucirumab. Of course, in that trial, there was no control group. It was a single arm, Phase I/II trial. So, further studies are pending. In fact, in the lung cancer master protocol in the United States, we actually have an arm of Pembrolizumab, Ramucirumab that is compared to a control of either docetaxel or docetaxel Ramucirumab. Bottom line is this combination is exciting and is continuing to be studied. There are, of course, other VEGF inhibitors that are being looked at with immune checkpoint agents. There's thoughts that it might have an effect both on antigen presentation, but also on T-cell trafficking. Of course, for a tumor to be receptive to PD-1 blockage, one needs to make sure you have T-cells in the microenvironment. So we have a nice poster here that combined the data, not only from the lung cohort, but also from the gastric cohort and the bladder cohort, and pulled all the data together and looked at patient samples and looked at the immune microenvironment. We actually showed through a number of different techniques, including looking at a gene signature for inflammation, that the more inflamed tumors, as you would expect, do better with this combination. So I think it's exciting. I think there's clearly something to be said about VEGF inhibitors increasing the immune environment to make it more inflamed and more susceptible. Will it work to increase primary resistance, meaning using it in untreated patients from immune therapy, or will we use it perhaps even in patients who have responded and then become resistant? These are all questions that remain to be asked. But this is a very nice poster, I think, that really shows that there are markers and signatures that can predict who may or may not better respond to this combination.